Okay, we're going to go ahead and get started. Hello, thank you for joining us today. My name is Christina Curry, and I am a Health Promotions Manager at the American Lung Association. I'll be helping moderate this session today for Dr. Domingo. Everybody, just some housekeeping rules. Everybody will be muted during the presentation. During the presentation, if you have any questions, please feel free to submit them in the chat box located at the right-hand side at the bottom of your screen, and we will address them at the end of the session. You will have to click on that little chat icon for that chat to pop up for you. So, to introduce our speaker today, Dr. Domingo from Memorial Cancer Institute in Fort Lauderdale is Vendor Guru, the VP of Oncology Services. I'm going to go ahead and play the video. I apologize. I realized there was no sound to the video. Let me play that one more time for you. I apologize for that.
Good day. My name is Vedna Gary. I'm the Vice President of Oncology Services for the Memorial Cancer Institute at the Memorial Healthcare System. It is my pleasure to be with you today to introduce the future of EGFR-positive lung cancer treatment during today's session and today's virtual patient meetup. The Memorial Cancer Institute is proud to be the sponsor of today's session and to partner with the American Lung Association on today's event. Now, more than ever, it is important to support making a difference in the lives of those living with lung cancer. At the Memorial Cancer Institute, we dedicate a large team of specially dedicated physicians and caregivers to provide lung cancer treatment. Our program really focuses on offering access to the latest advancements in care through our clinical trials and research, and also innovative techniques for lung cancer diagnoses and new technologies that enable treatment of complex lung cancers. During today's session, you'll learn more about the current treatments for EGFR-positive lung cancer. You'll hear about treatments that may be offered to treat EGFR-positive lung cancers in the future, strategies for talking to your doctors about current and future treatment options. Now, I'll turn the program over to Helena Domingo. Dr. Domingo is one of our oncologists here at the Memorial Cancer Institute, working for the Memorial Healthcare System.
So without further ado, I'm going to go ahead and turn it over to Dr. Domingo. Thank you, Dr. Domingo, for being here today.
Hi, good afternoon. Thank you for having me. So I'm Dr. Helena Domingo. I'm one of the thoracic oncologists at Memorial. And today we're going to talk about the future of EGFR targeted therapy. So just to start with some background, why is this important? Lung cancer continues to be the leading cause of death, cancer-related death worldwide.
Dr. Domingo, I'm sorry. Do you mind sharing your screen so we can see your slides?
And over here. Oh, share. I got it.
Perfect. We can see them now.
All right. Thank you. Let me move this over here. Okay. So to start over with the backgrounds, why is this important? Lung cancer continues to be the leading cause of cancer-related death worldwide, and it causes approximately 1.6 million deaths per year. Most of lung cancer is associated with smoking, and that's about 80% of lung cancer, but there are some lung cancers that are not associated with smoking. There are other carcinogens that have also been shown to have a link to lung cancer, such as arsenic, radon, asbestos, and others. But EGFR mutations are more common in lung tumors from patients that have never smoked compared to patients that have a history of smoking. Now, that doesn't mean that the patients that smoked can have a EGFR mutation. It's just more common on those patients that have never smoked before. The more common activating mutations in the EGFR gene are two, and those are the main ones that we have good targets for, and those are deletion in exon 19 and the L858R mutation on exon 21. In the US, there's approximately a 15% incidence of EGFR mutation in non-small cell lung cancer, but that percentage can be higher if the patient does not have a history of smoking. So what does this mean? What do we do with this EGFR? How do we know who has an EGFR mutation? How do we know who to treat with the targeted agents? So the first step, usually a patient will present either with a symptom. It could be a cough, maybe weight loss, maybe shortness of breath, maybe pain, or maybe they had a scan for another problem and they found incidentally that the patient has a mass in their lung. But the next step is usually to get a biopsy of the tumor or the mass to make a diagnosis of the condition. And it's important to know that there are several types of lung cancer and they're all not treated the same. The most common one is adenocarcinoma. Then the second most common is squamous, and then less common is one that's called small cell, which we'll not be talking about today. And there are others more rare types of lung cancer. But the one where we find the highest incidence of EGFR mutations are in patients that have adenocarcinoma. So once we have a diagnosis, we also need to do imaging in order to determine the stage of the patient. So usually we'll do a full body scan, like a PET scan or a CT scan, and we'll also need to obtain some imaging of the brain so we can scan the whole body. And then once we have that, then we can come up with a stage, because the stage is important to determine what treatment the patient would benefit from. And the stage is usually based on three things. T stands for size, N stands for lymph node, and M stands for metastases. And so if you can see it here on this chart, basically there's many numbers, but some of the things to keep in mind, it's important to know whether the patient has very early stage, like 1 or 2, because those typically are candidates for surgical resection, different from stage 3. So for stage 3, usually those are patients that their tumors are more than 5 centimeters, or they have a lymph node that's located on the other side of the lung or the middle, where the initial tumor is found. And the reason for that is because once the lymph node that's also compromised with the cancer is either in the middle or on the other side of the lung, the surgeon is unable to remove, both lungs or both sides. So that's not typically a case that we can take. And then T4 patients that have stage 4 cancer typically are patients that have some cancer that's outside of the primary organ. So that means that the tumor has moved from the lung where it started and it's spread somewhere else to some other organ. And that means the patient's stage 4. So like I said, typically for patients that have stage 1 or 2 disease, the main treatment is initially surgery. Some patients end up needing chemotherapy afterwards, but we decide that typically when the pathology comes back and we can look at it and make that determination. For stage 3 patients, typically we treat with a combination of chemotherapy and radiation. And most recently, after that, we put patients on immunotherapy as a maintenance therapy to prevent cancer recurrence. And so right now, the way that we're using this EGFR mutation is mainly for patients with stage 4 disease. So all patients that have stage 4 disease, it is standard of care to send something called molecular testing where we determine the molecular composition of the tumor. There's two ways we can do this. We can do it from blood. They can actually pick up DNA pieces from the tumor, and they can sequence them, and they can look for mutations there. And the other way is to send from the tissue where we took the biopsy, we send that to a company that performs the testing, and they're able to tell us the composition of the tumor and whether they have one of the mutations that we can target. So this is all being used right now mainly for stage 4 disease. And so if the patient has a target, then that is the first line of treatment, to try to treat the patient with a targeted agent that we have specific for that mutation that the patient has in their tumor. If they do not have one, then there's other options. We look for the PD-L1 expression. Some patients end up needing chemotherapy and so forth. So these are some of the other targets that we're looking for, but this is not the topic of our presentation right now, but just to give you an idea, there's other targets that we can also treat patients with agents like ALK, ROS1, RET, MET, NTRK, KRAS. And you can see here on this pie chart kind of the incidence of the mutations in the non-small cell lung cancer patients. So like you see here, for example, they report EGFR in about 17% of tumors. So what is EGFR? So EGFR stands for epidermal growth factor receptor. Basically, it is a protein that's located on the surface of the cell. This is how cells talk to each other. They have these, different proteins. This is one of them. And that one, the outside of the protein will bind to some molecule and bring it inside, and that triggers a pathway of chemical reactions, basically, that regulate how much the cell grows, when it dies, if it can form vessels, if it can move. And so this is based on the chemical reactions from interactions of this receptor and other receptors in the cell. But this one in particular has to do with cell growth, cell death, and cell mobility. And so while in normal cells, the tyrosine kinase is really tightly controlled, in cancer cells, these cells have lost that control. So the mutation in their gene makes the receptor work out of control, and that's why the cells are able to divide and spread, not like normal cells. And that's what drives the cancer. And so this is why these mutations are so highly sensitive to the targeted agents, because they're really going to the site that's making the tumor grow. This is an example of the EGFR gene and the different mutations that it can have. And basically here we go through a timeline. Initially, when the first tyrosine kinase inhibitor was discovered, we did not really know that it was to target that specific mutation. We were giving it basically to all cancer patients. And it was until later, in 2004, where the EGFR mutation was described. And then after that, we see that there's several agents that got approved. There's something called erlotinib, gefetinib. Then there was something called afatinib that was also used. And then most recently, osimertinib, that was found to have activity in patients that were treated with prior TKIs and developed a resistant mutation that's called T790M. And so it was approved for that mutation, but it was also approved subsequently as first line. Then this is afatinib and dacometinib, which we'll talk about later. So these are the same. This is the same as a prior slide. These are different types of tyrosine kinase inhibitors that we can use to target the EGFR mutation for those patients that we find that they have it. The good thing about the tyrosine kinase inhibitors compared to the prior treatments that we have is that it's not like chemotherapy. It doesn't have to be given IV. Patients don't need a central line to receive this. It's a pill. And the side effects, some patients can develop side effects. For the most part, it's pretty well tolerated, and it does not cause typically suppression of the immune system or nausea, vomiting. There are some patients that develop some skin rash. There are some patients that develop some diarrhea. With some TKIs are known to cause higher incidence of diarrhea compared to others. And we try to treat those with medications to slow it down and try to support the patient. But compared to the side effects of chemotherapy, is much better tolerated. This is a case. This is a 60-year-old patient that was initially diagnosed with adenocarcinoma, stage 4. As you can see, like we talked about before, these agents are being used mostly for advanced disease. Initially, it wasn't known that the patient had a mutation, so they received chemotherapy with carboplatin, pemetrexed, and bevacizumab, which are some agents that we use for this type of tumor. And then the patient actually also was treated with immunotherapy. This is what's called nivolumab here. And then later on, they were found to have an EGFR mutation, and they started treatment with a TKI. And if you can see here, the top picture, these are the lungs of the patient. They're supposed to look like the bottom ones. Like usually lungs are filled with air, and they look gray or dark. But all these white spots here are tumors. And then 2 years later, this is what the patient's CT scan looked like the picture of the bottom, still doing well on the medication. So very effective for this type of tumor. These are some of the clinical trials that were done initially to get these agents approved. And these are some of the early data that we have. And you can see here that it showed a benefit in median progression-free survival, means how long the patient is without disease recurrence. The overall survival data did not show a big difference, and that's because the patients that were on chemotherapy eventually were transferred over to be treated with the TKI because they noticed that it was so effective. Now, this is a trial. It's called a FLORA trial. It's when they compare osimertinib. I don't know if you remember looking at the list, but osimertinib is one of the newer generation tyrosine kinase inhibitors. So they compared, recently we have data comparing this one, the newer generation inhibitor, to the older one, like erlotinib and gefetinib. And what they saw is that osimertinib showed a significant increase in progression-free survival, which is, again, the time that the patient is cancer-free, compared to the older generation TKIs. Additional data later came out last year, and is also showing an increase in median overall survival, where the prior TKIs, the overall survival was like around a year and a half. This one showing over 3-year progression-free survival, overall survival benefit. And also, osimertinib crosses the blood-brain barrier, and so is active for brain metastases. So patients that have brain mets also benefit from this. Now, afatinib, not as active as osimertinib. We don't have data comparing it like this to older TKIs, but there is some data that it can work on the patients that have rare mutations, not the two that we talked about, the exon 19 and 21, but there are other mutations in the EGFR receptor that can be treated and are responsive to afatinib. So this is something to keep in mind for patients that have these rare mutations. Now, what is the future of this? What we talked about before is already standard of care. So if a patient comes in with stage 4 disease, we must send molecular testing to figure out the molecular composition of the tumor. And if they have an EGFR mutation, that patient has to be treated with an EGFR targeted agent. Now, currently, the preferred agent is osimertinib because it showed the best survival data and progression-free survival data when compared to the older generation TKIs. But unfortunately, with time, even the patients on osimertinib, after 3, 4, everyone's different, but patients, unfortunately, their cancer cells become resistant even to the osimertinib, and they start to grow. So now, looking into the future, we're trying to see what other strategies we can use to salvage the patient, to keep them from progressing. So this is a trial that showed additional bevacizumab, which is a agent that stops vessel growth. Tumors need vessel to bring blood supply and nutrients and keep growing. So it's a combination of the TKI with bevacizumab. The trial is still ongoing. We're waiting for the final data to come out. This one is another trial that's showing combining osimertinib, which is the newer generation TKI, alone versus osimertinib with chemotherapy for newly diagnosed patients. And again, this one's ongoing. So as you can see here, a group of patients at the bottom just receives osimertinib, and then the other group receives cisplatin, carboplatin, pemetrexate with osimertinib. And then they put them on osimertinib therapy and they follow them with scans, and they compare one group to the other to see who does better, whether adding chemotherapy to the TKI has benefit for them. We're also waiting for the result of that trial. Now, also looking to see for the patients that progress on osimertinib, why do they progress? So they have found that the tumors come up with mechanisms to evade that blockade from the TKI. And one of those examples is they develop another mutation. So remember when we talked back about having different other mutations that we can target? One of those was a MET amplification, and that's been seen in several of the tumors that are growing despite the osimertinib. And so based on that, we can try to come up with ways to block that. These are other newer EGFR TKIs that are being tested. And also there's a couple of agents that are undergoing clinical trials for one of the more rare EGFR mutations, such as exon 20. There's an agent that's called TAC788. And that's they're undergoing trials. Is showing some promising data, as well as this is the agent here, TAK788, and also there's another agent called poziotinib that's also being tested and showing some positive results, but we're still pending additional data from the trial to come out. Other ongoing trials are combining this agent, amivantamab. This is a monoclonal antibody that also attacks the EGFR receptor, and plus lazertinib, which is another TKI. The combination of these two for patients that have relapsed or progressed on osimertinib. And we just have early data. We're waiting for the data to mature, as well as they're trying to treat patients up front with a combination of two TKIs to see if they can prevent that resistance from developing. So in summary, the key to precision medicine is molecular testing. So all patients that come in, especially with stage 4 disease, need to have molecular testing so we can determine the composition of the tumor, whether they have EGFR or ALK or ROS1, and that way we can best determine what treatment is going to work the best for that specific patient. EGFR TKIs is the standard of care in first-line EGFR mutated stage 4 lung cancer. And right now, the first choice is osimertinib because it has shown the best data, but there's also other agents available like dacomatinib, afatinib, erlotinib, and gefetinib. Adding chemotherapy and VEGF inhibition to osimertinib may improve outcomes, but we're still pending for data to come out with osimertinib for this. And then the data with other EGFR inhibitors that they're testing are also ongoing trials. We're waiting for that data to mature. We're also waiting for the agents that block the exon 20 mutation that we talked about, poziotinib and TAC788. And we're also trying to see if we can prevent osimertinib resistance by starting 2 TKIs at a time instead of 1. So all those clinical trials are ongoing, and we have to follow up and see if they have positive results, and it may be something that benefits the patient. And that's it. These are some pictures from our hospitals. And I'll open up for questions if you have any questions for me.
Dr. Domingo, there was one question. Will the slides be available to us after the presentation?
Yes, you can have the slides.
Okay, thank you. So, yep. If you have any questions, please go ahead and enter them in the chat box. It looks like, there's one question. Have you heard of IRESSA? I'm going to spell it IRESSA.
I'm sorry, can you say it again?
Have you heard of irises? I'm sorry, apologies. I'm probably pronouncing it wrong. It's spelled IRESSA.
IRE?
SSA.
Yes. Second. Yes, that's this drug right here. So all these drugs that I mentioned here, they have a genetic name and a brand name. So this drug gefetinib, the brand name for gefetinib is Irisa. It's one of the first generation of TKIs that we've talked about in the PowerPoint. Let me see if I find it. Oh, yeah. Here, I think it's here. It's this one here, Jeff. That's gefetinib. Here. Was there a specific question about that?
No, they just asked if you've heard of it. And then there's also, is Amphiba typically started alone or with combination?
Which one?
And Amphiba, AFAPINIB.
Oh, afatinib. No, so these TKIs right now, the way that are approved is alone. We're testing to see if giving them in combination with other things are beneficial, but we still don't have the data to guarantee that that's the case. So that's still undergoing clinical trials. But what's the standard of care is just treating patients with one TKI.
Thank you. Another question is radiation common with Tagrisso therapy?
It's typically not given in combination, but every patient is different. Sometimes we use radiation in combination with chemotherapy for stage 3 lung cancer patients, and that's standard of care. There are some patients that are stage 4 and they're taking Tagrisso, but they need radiation for palliation of pain or other reasons that they can have radiation during the treatment. And we have given it like that.
Thank you. Another question is what over-the-counter supplements, if any, are recommended for this type of cancer?
Um, um, I mean, they're really over the counter. I'm not sure that there's any recommendations to take anything over the counter. I don't think we have any evidence that there's some that would benefit the outcome of the patient or improve the survival. Typically, when patients are receiving chemotherapy, we tell them to stay away from taking multivitamins because some of the vitamins may interfere with the effect of chemotherapy. With the targeted therapies, it may be a little different. We're not sure, but it's not something that the oncologist will typically recommend.
Thank you. Is this type of cancer hereditary?
So lung cancer in majority is associated with smoking. So 80% of lung cancer happens in patients that smoke. And then there's another 20% that happens in patients that don't smoke. Now, from those, sometimes we find out that they were secondhand smokers. Sometimes it's hard to tell. It's hard to assess how much exposure the patient had. There's other gases that can cause lung cancer. It's not really thought as a genetic, like it's not like the BRCA that causes like breast and ovarian. We don't have something like that for lung cancer. It's mostly thought as something environmental. And, in some cases, unfortunately, we can't really figure out what caused it.
Thank you. So this one said, I have been on Osmer Tibnamian. Sorry, I'm horrible pronouncing these names. Since June. So far, so good. Wondering about interactions with Chinese herbs.
Yeah, again, even for us, sometimes it's hard to tell because some of these herbs, we don't know the content of them. So I would say not to take them because I don't know if it's interfering with the efficacy of the medication. For here, sometimes our patients will bring whatever they're taking, and we'll take it to the pharmacy, and they'll try to run it on the internet and see if they can figure out the contents of what they're taking to see if we, maybe see if maybe it's a little more safe. But in general, I would say to avoid.
Thank you. Here's another question. What is the harm to start Tagresso if it's the last option? Knowing it basically starts the clock on your time, wouldn't it be better to wait to start it? You have small nodules, 10 mm's in size, in only one lung.
If you have small burden of disease, obviously, like the patients, some patients present with asymptomatic disease, and some patients present with more symptoms. Um, Typically, we recommend treatment from the beginning because when the tumors are smaller, it's easier to control them. It's easier to make them shrink versus when you have a larger tumor. The other thing is larger tumors secrete inflammatory cytokines that have effects in your body. Like with time, patients start to lose appetite, to lose weight, to get weaker. And sometimes if the patient becomes so weak that they cannot even tolerate the treatment. So that's the problem. Or sometimes, let's say the patient develops a complication because the tumor got large and now they develop a blood clot in their lung, or now they develop a post-obstructive pneumonia, and they ended up with an infection. So there's things that can develop from having tumors grow that are not getting treated, especially if we know that we're dealing with lung cancer. It grows in a typically, they're all a little bit different. Some grow faster than others, but for the most part, it's not like maybe some slower growing cancer, like maybe uh, more benign, like a thyroid cancer. There are other cancers that grow slower, or like a low-grade neuroendocrine tumor that may take maybe like several years. Lung cancer, usually if it goes untreated, maybe like in a few months it will double in size. It's not a tumor that typically grows very slowly. So for the most part, I don't think most people recommend waiting for symptoms to start treatment.
Thank you. Are any of these TKIs used for someone following successful chemo/surgery/radiation treatments for a stage 3A patient whose tumor was EGFR exon 19?
I'm sorry, can you repeat that?
Sorry about that. Are any of these TKIs used for someone following successful chemo, surgery, radiation treatment for a stage 3A patient whose tumor was EGFR exon 19?
So the patient has stage 3A and then had chemo and surgery and chemo, I'm guessing. Surgery first, then chemo
It says chemo/surgery/radiation. I believe
and
it's
radiation.
hmm
And is the TKI used in this setting? So if the patient, I'm not sure so typically we do either surgery or chemo radiation. There are some patients that undergo surgery, and when the pathology comes back, it's showing something called positive margins, where the margin means where they resect the tumor at the edge. That's the margin of the tumor. It's positive. When we see that, then we know that on the other side that was left behind in the lung, there's also cancer because it's right at the edge. So that's called a positive margin. That tells us that there's tumor left behind. So for a patient like that, sometimes after surgery, we recommend chemotherapy and radiation in combination. And then after that, there's no indication to start. It's not FDA approved to start a TKI. I'm not sure if the insurance company would approve for that. It's not approved in this setting. Usually, what the standard of care is after this happens, we watch the patient. If they have a relapse of their cancer, then that would be a time to start the EGFR targeted agent.
Thank you. Can you explain the studies of irises? Irises.
Let me see if I find that. So, these studies are a little old. I don't have the year here. Or yeah, it's like 2009, 2010. So this is one of the first TKIs that came out in the US. And it was like after it was taken off the market, and it's not one of the ones that we typically use here. Now, the first generation TKI that we typically use is erlotinib, but even that one we're not using so much anymore. Maybe let's say like there's a patient that started taking it back then and they're still doing well. There's no indication to switch them over to another treatment. But it's not one of the TKIs that we typically would start on a patient now, especially since the new data from the FLORA study came up comparing the Tagrisso with the Iressa and the Tarceva. The Tarceva is the erlotinib, and that it showed that it's a much better, more potent agent. So after this data came out, which is recent, it's from last year, we no longer start patients on first line, first generation TKIs. Now we start patients on mostly on osimertinib.
Thank you. How long does a clinical trial take? I have EGFR exon 20.
I see. If you have that, that's not, we don't have a therapy for that that's FDA approved, but you can actually enroll, we can look to see where the trial is being held, and you can try to enroll in the trial and receive the therapy that way. Typically, this trial they take several years.
Is CBD oil okay to use in conjunction with treatment?
Yes, that's fine to use.
How long does I'm sorry, it's the OSIMERTINIB continue work? That I think it's the Tagrisso, the pharmaceutical name of it.
Okay, so the Tagrisso, it showed an overall survival benefit of over 30, 34, 36 months. That means that, some patients live longer than that and some patients live less. But that's the typical average time that you're alive when you're on that treatment. But everyone's different. And again, patients that progress on this and they have only been treated with Tagrisso, then we can consider second line treatment with other options. So to say like how long the patient's alive, it's hard to tell.
Is non-small lung cancer seen more in non-smokers than smokers? In other words, which subtype of NSCLC is seen more often? Is seen more often in non-smokers if that has been determined.
So lung cancer is mostly seen in smokers. So patients that have lung cancer, 80% of patients were smokers, but there's a percentage that doesn't have a history of smoking still got lung cancer, and we're not really sure why. There's a thought of these other agents that they're carcinogens that patients could have been exposed to. Some patients really deny being exposed to any of these other carcinogens that we know that can lead to lung cancer, and we don't really understand what caused the lung cancer. But there's a type of lung cancer that's called small cell lung cancer, where 99% of patients were smokers. So that one's almost 100% linked to cigarette smoking. And the other ones, the adenocarcinoma and the squamous, are typically the ones that we find sometimes in patients who do not have a history of smoking. Did that answer that question?
I think it did. Here's another question. Is there an average time that the EGFR TKIs work? I was told they work until they don't. I've been on an amphibia. Sorry, how do you pronounce it? It's the AFATAN amphibia for a year with decrease in tumor size and decreased brain meets. But if scans go to every 6 months or even to a year, how do you know if it's not working anymore?
You meant the afatinib?
The afatinib.
Oh, okay. No, so you can look at a clinical trial. So basically, when they approve these drugs, they give it to a patient and they compare it to the standard of care, which in the case of patients with lung cancer at the time was chemotherapy. So initially, patients diagnosed with stage 4 lung cancer, survival was like less than 6 months. Then with chemotherapy, we can push that out to like a year. And then when the TKIs came up, we can push that out longer than a year. Now, how long the patient's going to respond, these numbers are not set in stone. Some patients don't respond at all. Start taking them, you get the scan, they're progressing, and then some patients respond very well and have a very prolonged duration of their response. So usually what we do is we give the medicine and we monitor with periodic scans. We compare them to the prior, and then we see how the medication is working. If the patient develops a side effect, that they cannot tolerate the treatment, that's an indication to either reduce the dose or change the medicine. And if the patient, we get the scan and it's no longer working, that's also an indication to think about a different treatment option.
Thank you. What are second line treatments after Tagresso?
So once a patient has failed targeted therapy, we can send for molecular testing again and see if the reason they're failing is because they're developing another mutation that's the path for tumor growth. And if we find something that we can target, that would be the preferred treatment. But if the patient has nothing like that we can target, then we have to consider doing chemotherapy and immunotherapy.
If Tagresso stopped working, would you go back to a first or second generation drug like Trevecca, Tar, Tarsivia?
Tarsiva. It depends, it depends on the mechanism why it stopped working. So if the mechanism why it stopped working is that they developed another mutation and there's another TKI that can block it, then we can move them to a TKI. But that's not the most common thing that we find, and so it's not the most typical. Most patients that progress on osimertinib end up needing some form of chemotherapy or immunotherapy after.
When will the data be available regarding TKI resistance and the use of two TKIs together? What two TKIs are they using together in clinical studies?
Um, so regarding when the data will be measured, I'm not really sure. These trials usually take a few years because they have to follow the patients along and see how they're doing. Um, but uh, but regarding which TKIs they're using in combination, I know there was one trial that they're using osimertinib. Well, there was some that they were using the lazertinib with that monoclonal antibody, and then for the dual combination, they were using osimertinib plus dacometinib, which is also a newer generation ones that we mentioned, and there was one where they're testing osimertinib plus gefitinib in the first line setting. So starting off with those two instead of one. But those trials were recently started. I don't think that the data takes a little bit to mature. It takes a few years.
How many different molecular tests are available?
So there's many, but typically what we're doing now is we send it to a company that runs everything. So they run a full panel, and they provide a report where all the targets are tested for, and they're reported positive, negative in terms of PD-L1 expression, which is the marker that we use to see how responsive the patient would be to immunotherapy. They're able to provide a percentage of that, and so we look at the whole report, and that helps us guide the treatment to the patient.
A follow-up to that question, what is the name of that test?
So it's called molecular testing. There's different companies that perform it. There's a company that's called Caris that we work with. There's one that's called Foundation One. There's one that's called Gentech. The one for the liquid biopsy that we usually use here at our institution is called Garden. So there's different companies that provide the services of testing the tumor and to check if the tumor has one of these molecular targets.
Okay. I believe that was our last question. Is there any more questions for Dr. Mia? Oh, is there a benefit of retesting a year or two later?
So usually we test the patients at diagnosis. We start a treatment based on all the information that we have. And if the patient is doing well, let's say they're doing well for 2 years, but at 2 years they have one area that's growing. Sometimes the thought is that maybe not all the tumor, but that area that's growing is growing because it developed a new mutation. So yeah, a lot of the times we'll send a patient for a new biopsy and retest molecular markers of the area that's progressing.
Okay. Can you talk about Asmerda and caffeine and alcohol interactions?
I mean, I'm not sure that it has an interaction per se. I would say if you're having side effects from the medication, like some patients get some issues with mouth sores, you're not feeling well. I don't know how that would play depending on how much alcohol you use. But as far as I know, if you want to have a glass of wine or something like that, I think it should be fine.
How often do you scan? How often do you I'm sorry. How often do you scan on patients on Tagresso?
So usually after every 3 months.
If Asmerda stops working, can anyone have immunotherapy, or do they have to have something that shows it will work?
So it depends, it's a clinical decision. So typically, immunotherapy is approved by itself for patients that have a PD-L1 expression of over 50%. And that's part of the testing that we do when we send off the molecular test. It comes back. So we know how high it is. And that's indicative that it can have a response by itself. If the patient has a high tumor burden, that means that there's a lot of tumors. Sometimes we still want to give it in combination with chemotherapy because chemotherapy is able to reduce the size of the tumor much faster than immunotherapy is. Immunotherapy is an agent that we have that basically activates immune cells to find and kill cancer cells, but it's kind of a slow process. And so if the patient's already symptomatic from so many tumors, and maybe we call cytoreduce them, meaning kill some of the cells as fast as we can. We still give it in combination with immunotherapy. So it depends on the case as well.
If I'm EGFR positive 3 years ago, but am now high risk for lung collapse, would a liquid biopsy be sufficient for starting Tagresso?
I'm sorry, you EGFR for 2 years?
Yes, EGFR positive for 3 years. Was positive 3 years ago.
Uh-huh. And were you on treatment?
Let me see if she chats in. No, I had surgery and then radiation.
Surgery and radiation. And now you have a recurrence? I see. I would test it again. Yeah, they can try, you can check. The liquid biopsy basically is just take a sample of your blood. They send it off. They fish out for these fragments of the DNA from the tumor, and they try to find the EGFR mutation because they're fishing out. So can you only imagine, like these DNA fragments are microscopic, and it's just because we have this PCR technology that can duplicate fragments of DNA and multiply them to a size that we can detect a mutation. But sometimes, it's not 100%. Sometimes the tumor is not shedding enough DNA, or they don't pick up the fragment in the sample that they take, and so it's not 100%. So sometimes, let's say you have a tumor, a liquid biopsy, and they send it and it's negative, it could still be found in the tissue. So they're complementary. Complementary. Typically, we want to have both. We want to do the tumor and the blood. But if you're not able to get a sample of the tumor because you are high risk of, intubation, or respiratory decompensation or something like that, yeah, definitely. At least you can try the liquid biopsy. If it shows up there, that's enough. We don't have to prove it in both sides. I'm just saying, like, sometimes if you test it and it's not positive, it's still possible you have it.
Okay. Thank you. Any more questions, Dr. Domingo? I believe that was our last question. Thank you so much, Dr. Domingo, for taking the time out of your busy schedule to be here with us today. I definitely learned a lot more about EGFR, and we really appreciate you joining us today.
Thank you. Thank you for having me.
Thank
It's
you.
a pleasure. Okay.
And please be sure to fill out the evaluation for today's session. There will be 2 questions on Dr. Domingo's presentation. You will receive 25 points each for completing both the breakout session and the main evaluation. Evaluations can be found on the Get the Agenda icon, where there are links on the bottom of the agenda document. Thank you again for attending Dr. Domingo's session today. We hope you enjoyed it. You will be now going to navigating lung cancer clinicals during COVID. Have a great rest of your day. Bye. Thank you for joining.